Introduction to Nursing Concepts Nutrition. This is part 2. Martha Olson from Iowa Lakes Community College. As we look at assisting with eating, then we can see there's a lot of suggestions on page 1026 in Potter and Perry, skill 44-1. Looking at aspiration precaution is our biggest concern. Other things I would recommend to help people have a pleasant eating experience: get rid of the odors. Take out the wet attends and the things in the room that maybe are not very nice smelling. If you have a person that's nauseated, if you can give them an antiemetic 30 minutes before eating, that's usually very helpful. Do not delegate the feeding to another CNA if they have a risk for aspiration, or possibly a new admit that you don't know how well they eat or how well they're swallowing and chewing. Use the thickening agents. You don't have to have an order for that if you feel like they're a risk. And like I said in the last video segment, about 1/2 to 1 teaspoon of food on the unaffected side. So if they had a stroke on their left, you would try to put the food into the right side of the mouth. Keep them upright for at least 30 minutes. That helps with GERD and aspiration issues for them. In long-term care, they usually have what we call a feeder table, and that is residents that need to be watched for choking, and you have to have somebody at that table before any food or trays get brought to them. So just a couple of things with long-term care. As we look at diet intake, calorie count, like I said, daily weights can be obtained, or weekly weights without an order. And then how do we know about advancing the diet? How much did they eat? How well are their bowel sounds? Are they up and walking? Are they having bloating or issues with nausea or regurgitation? When we look at fluid, remember 2.2 pounds is 1 liter of fluid. So if you weigh a patient and they've gained 2.2 pounds, they probably have 1 liter of fluid on board somewhere because they're retaining it. Intake is measurable if it melts at room temp. So if you give them sherbet or ice cream or a popsicle, you have to count that as intake because it melts down. There are other foods that are very high in fluid intake that don't melt down, but you kind of need to consider, watermelon. When you eat watermelon in the summer, you get a lot of fluid with that. Lettuce is the other food that has a lot of fluid in it. Output is anything that you can measure: urine, vomit, any drains, NG drains, hemovac drains would all be counted as output. And then again, remember patients or different situations, we would encourage fluids. If somebody's had barium, had any kind of barium in a test, we want to flush that through their kidneys, so we would encourage fluids for them. Patients with kidney stones would need high fluid intake to try to push or force that kidney stone out. Again, your patient that has a high metabolism, they're recovering from surgery, had a lot of tissue damage, those types of patients we would want to encourage, the Ensure, the Boost, the calories of any kind. Getting into enteral nutrition, then, this is found on page 1031 at skill 44-3. We want to look at enteral nutrition being used going into the GI system. So this is a patient that has bowel sounds, that has no problems with their lower. Usually enteral nutrition is because they have upper airway issues. They've had throat cancer and they've had radiation. Maybe this is a kid that had cleft lip, cleft palate surgery, and we need to feed them into the stomach or the jejunum, and it will be absorbed and digested and go through. For any of the enteral nutrition, remember we need to check blood sugars because the Gevity or whatever product we're using tends to be very concentrated with sugar. It's a concern even if they're not a diabetic. Always want to start out with a weight for a baseline to know, are they losing weight? Are we giving them enough nutrition? Or maybe the opposite, we're giving them too much and they're gaining a little bit too much weight. Check the formula, make sure it's room temp. If it's too cold, it's going to cramp and give them problems with bloating and maybe dumping syndrome. Look at the rate, the route, how often. We don't want to hang longevity any longer than 4 hours because it's sugary and it grows bacteria. So usually we put enough in that it will run 4 hours. We flush, we check our placement, we check aspiration to see if they're retaining any, and go from there. The tubing, also remember, with your pumps is changed at least every 24 hours per protocol, and that's again because it's got sugar and it grows bacteria. So IV tubing is changed every 3, but to your Gevity pumps, they're usually changed per protocol every 24 hours. Look at the site where that PEG tube is going in, listen for bowel sounds, check for distension or other complications with that GI system as we administer enteral nutrition. We always want them in high Fowler's position because as it goes into the stomach, they can aspirate it. Check placement by aspirating 5 to 10 milliliters, and then it, remember, gets put back in, and the purpose for putting that aspiration back in from the syringe that you've pulled out is to give them back the pH, give them back the acid so that they can maintain that pH in their gut. And then look for complications. On table 44-7, it talks about, many we can prevent with proper care and early interventions. Keep the head of the bed up. That's a very common question on NCLEX because it's a safety question. Liquids, we want to use liquids. Don't crush pills unless we absolutely have to because they occlude the tube. As far as fluid overload, continue to watch intake and output, listen to lung sounds, and then for the hyper or hypoglycemia, know your signs and symptoms of that, and check the blood sugar if you at all have any questions with that. Why would a patient have risk for aspiration, less risk with the jejunal feeding? And as we think about that, your jejunum is further down. It has that pyloric sphincter, and so your risk for aspiration is less for that person. And the signs are not tolerating a feeding. They're bloated, they have diarrhea, they have a lot of residual when you check that. Parenteral nutrition then is used when we cannot use that GI. I think of your patient with Crohn's disease where anything that gets put in that small intestine just runs right through. It's not absorbed. So we have to figure out a way to let that part of the GI system rest. And that is accomplished by what we call parenteral nutrition. It is going right directly into the bloodstream so that it is absorbed and used by the body. It's a lot more expensive. You have to have either a central line or a PICC line. And usually it's done in the hospital simply because the PICC line and the central line have a very high risk for infection and complications with an infection being right there on the superior vena cava. So I don't often see these in the home, but that doesn't mean that they wouldn't be. With these, they are made by the pharmacist. The dietitian looks at the diet, the lab values, confers and collaborates with the pharmacist to come up with the exact formula that they are going to make for the nutrition that's hung, and then it's made in the pharmacy. The nurse will hang it. It's got electrolytes, amino acids, vitamins, minerals. The lipids are put in differently. The lipids are kind of a milky white. They come in a glass bottle, and usually we do the lipids about once or twice a week. Remember, fat-soluble lipids then the body is able to hold on to, and so giving lipids once or twice a week, the patient will have adequate because the liver will save them, whereas the electrolytes and the other vitamins from that person, the water-soluble vitamins, are eliminated and have to be given on a more regular basis. Remember, it's a sterile technique when we're using any type of central line. This is found on page 1021 in your Potter and Perry. We would use this with very severely ill patients that have sepsis, maybe head injury, burns, where they need a lot of calories and their GI system is not working like we want. On page 1021, it talks about disuse of the atrophy of the villus. So remember, the cells can shrink. If we're putting it into the bloodstream, we have to think about what is the long-term consequences to that GI system. Their peristalsis obviously will diminish, And they can also get what the Potter and Perry textbook calls gram-negative septicemia. That's where the bacteria actually leave the gut and go into the bloodstream, causing a lot more problems for that patient. In the fat emulsions, your book talks about, again, hyperglycemia being a concern, and then using a Y connector tubing because it has to go into a separate central line. As we compare and contrast the nasogastric tube with the PEG tube, remember the nasogastric is going to go down through the nose. It's a very short term. We don't want to have complications to the nose or that cardiac sphincter because of that NG tube placement being down. And then your PEG tube is usually more of a permanent. It goes right into the stomach from the abdomen. We flush it, we maintain it from there. Other things to look at on page 1024, it talks about GI diseases such as peptic ulcer diseases. Meals and H2 antagonists or proton pump inhibitors are recommended for that. Our H. pylori causes peptic ulcers. That needs to be eliminated through decreasing stress and irritating foods such as coffee, citric acid like orange juices, chili powder, smoking, alcohol, aspirin, any of your NSAIDs. Over-the-counter NSAIDs are very irritating for that. Crohn's disease, the other name for that is a colitis, and that's acute inflammation, and as I said, usually requires your total parenteral nutrition. Celiac disease, the gluten-free diet. And then a patient with diverticulitis with the inflamed diverticula usually need like a low residue diet that kind of slides through. Your diabetes, from your nutrition, you should have had, the type 1 is your insulin dependent. Your type 2 is usually on exercise diet, maybe a metformin or some of the meds for type 2 diabetes. But both type 1 and type 2 need to watch carb intake. That's the key to the management of that disease. And our goal, number one goal, is always blood sugar control. With cardiovascular, we want to lower the saturated fat in the diet and the sodium. For our cancer patient, it talks about, nutritional problems being a huge issue. Cancer increases the metabolic needs, so many times they will lose weight. They will have what we call cachexia or the wasting syndrome. And then any type of the chemo and radiation always causes complications for the patient. And then your HIV patient has the wasting syndrome, oftentimes get oral thrush with that. Our evaluation is looking at, how are they doing? Are we meeting the goals of maintaining weight? Are the lab values where we want? Are they getting enough calorie intake? And these are talked about on page 1025 in Potter and Perry. When we look at our terms, we've talked about all of those in the 2 slides we've had. When we document our tube feedings, we always want to look at the things to the right. How much do we pull back in the syringe? That's our residual. Document that as the color and the amount in milliliters. The rate and strength, how fast are we running that tube feeding in, and then is it half strength, full strengthevity, because that helps us to know, are we maybe giving them too much sugar too quickly. And we always flush with just tap water. The stomach is not a sterile organ, and flushing with tap water is appropriate. Our special considerations, thinking about the pediatric and the amount of protein and growth that goes on during that first year is amazing, and so they usually double their weight by 5 to 6 months. Breast milk versus formula was discussed in nutrition. They both have about 20 to 21 calories per ounce, but obviously the breast milk has the immunity, the colostrum, some of those added benefits for that infant. When we look at the aging, we remember that they need just as much energy and nutrients, they just don't need as many calories. The grapefruit and grapefruit juice is usually because they're on medications for cholesterol that interfere with that, and many times they lose their thirst sensation, so they aren't drinking as much as they should, and getting dehydrated can be an issue for them, and we need to encourage them to drink so they don't get a UTI. Homebound older adults, remember with chronic illness, they have a lot of increased risk, especially if they live alone, they have no social support. 19% of our older adults have some food insecurity, either from low income or poverty. And there is a nutrition screening tool on page 1008. This ends the nutrition unit. Thank you.